and CHIP Services. She's now going to walk us through the Medicaid demonstration opportunity. Nancy, over to you.
Thank you so much, Ruby. I really appreciate it. And I appreciate the opportunity to be here today with you on behalf of CMS to talk about the Medicaid Reentry Section 1115 demonstration opportunity. Next slide, please. Next slide. I want to go ahead and start with some Medicaid basics for you. Our implementing legislation in Medicaid is in Title 19 of the Social Security Act. And Medicaid is a jointly funded partnership program between the federal and state governments. It is a state administered program that has to follow federal Medicaid rules. So policies and programs vary tremendously from state to state. And this variability among state Medicaid programs is going to be a theme that will be echoed throughout the presentation today: federal requirements and state flexibility. Next slide, please. Continuing with Medicaid basics, some of the areas where there is state flexibility within those federal parameters have to do with choices that states may make about determining the extent of who is eligible, establishing eligibility standards, determining the services available, including the amount, duration, and scope of services, the providers of service, the delivery system for services, whether it's in fee-for-service or managed care or some combination, setting payment rates for services, and administering the day-to-day operations of the state Medicaid program. So because of these types of state decisions that affect Medicaid programs, discussions around Medicaid generally need to occur on a state-by-state and not a federal basis. Next slide, please. So turning to the Section 1115 Demonstration Authority, which is the authority for the reentry demonstration that I will be talking about today. Section 1115 is also in the Social Security Act. It gives the Secretary of Health and Human Services authority to approve experimental, pilot, or demonstration projects. These projects are likely to assist, must be likely to assist in promoting the objectives of the Medicaid and children's health insurance programs. Each application from a state is reviewed on a case-by-case basis to see whether its objectives align with those of Medicaid and/or CHIP. And CMS also considers whether any proposed waivers of Medicaid rules and expenditure authority of federal money are appropriate and consistent with federal policies. 1115 authority is used to waive or disregard rules in Medicaid that are generally not available to states through other Medicaid authorities. Demonstrations must be budget neutral to the federal government, and generally, Section 1115 demonstrations are approved for an initial 5-year period, and states commonly request and receive additional 5-year extension approvals. Next slide, please. So I want to talk a little bit about individuals who are incarcerated in the Medicaid program. There is a long-standing statutory exclusion that goes back to the beginning of Medicaid in 1965 that does not permit payment for services to individuals who are incarcerated through Medicaid. You may have heard it referred to as the Medicaid inmate payment exclusion or the inmate exclusion. Next slide, please. So, incarceration status is not, however, a factor in eligibility for Medicaid. Incarcerated individuals may be eligible for Medicaid and enrolled in Medicaid, but because of the inmate payment exclusion, no services may be paid for. There is, however, one exception, and that is for inpatient services in a medical institution. I would also like to point out that a person who is on parole, probation, residing in certain types of halfway houses, on home confinement, or some other restrictions through the court and not incarcerated is not considered an inmate of a public institution for purposes of Medicaid and therefore not subject to the inmate exclusion. Next slide, please. So how did the demonstration come about? Section 5032 of the Support Act, titled the Medicaid Reentry Act, authorized this legislation to help incarcerated Medicaid individuals transition more successfully from incarceration to the community. There are three key components in this legislation: the convening of a stakeholder group, a report to Congress on best practices to help individuals transition from incarceration to the community, and for CMS to issue a state Medicaid director letter authorizing an 1115 demonstration opportunity to help individuals who would be soon to be released from incarceration transition more successfully into the community. There are links on this slide to both the report to Congress and our state Medicaid director letter. Next slide, please. So there are some very compelling reasons to address the needs of the incarcerated population in Medicaid. Numerous studies show that incarcerated individuals have very high rates of both physical and behavioral health conditions, much higher than the general population and the general Medicaid population. You see on the slide the rates of individuals with mental illness who are incarcerated and the rates for substance use disorder, which are even higher. Also, individuals experience high rates of such physical conditions as hypertension, asthma, tuberculosis, HIV, arthritis, and hepatitis. So given these statistics, improving healthcare transitions for incarcerated individuals is critically important. Many incarcerated individuals are Medicaid eligible. And so access to services, both pre-release while an individual is incarcerated and then post-release when they return to the community, are very important and may help these individuals have greater stability in their lives. Next slide, please. In our state Medicaid director letter and within this demonstration, states are expected to address demonstration goals. All of these goals are aimed at addressing healthcare and related needs prior to release for incarcerated individuals and to increase linkages to care and services in the community for which a person would be eligible upon release. And all of this is for the purpose of improving the transition for individuals who are Medicaid eligible from carceral settings to the community. The individual goals that we expect states to address include increasing coverage, continuity of coverage, and service use, improving access to services, improving coordination and communication between criminal justice, Medicaid, and healthcare services, increasing additional investments in healthcare and related services, improving connections between carceral settings and community services providers, and upon release, reducing deaths, emergency department visits, and inpatient hospitalizations. Next slide, please. All states in their demonstration application are expected to address quality and health equity. States should consider how they will advance quality of care and close health disparity gaps by promoting access to health care and addressing health-related social needs. This goes beyond just physical and behavioral health care, looking at housing, employment, access to food, and other social services that individuals may need. And in our guidance, we also strongly encourage states to engage individuals who have lived experience of incarceration in both their demonstration, design, and implementation. This was based on stakeholder input from the stakeholder group and is also reflected in the report to Congress. Next slide, please. So going back to the theme I talked about, this is an area where states have choices. States may choose amongst a variety of eligible individuals. So the pool of eligible individuals for this demonstration opportunity would include currently incarcerated individuals who are Medicaid eligible and close to release. And this could include current Medicaid eligible beneficiaries, as well as individuals who may be eligible but not currently enrolled. States do have choices they could choose to further target the population they serve. For example, they could target their demonstration to individuals with substance use disorder, serious mental illness, some types of physical health conditions, or some combination. For states that do choose to target the population, they will be expected to identify criteria and processes to do so, and they should be mindful not to overlook individuals with undiagnosed conditions as they develop these criteria. Next slide, please. So turning to Medicaid eligibility and enrollment, states should be working with their correctional facility partners to start the Medicaid application process early and to assist already incarcerated individuals who are not currently Medicaid eligible to apply for Medicaid. And in this demonstration opportunity, states will be expected to suspend and not terminate incarcerated individuals' eligibility status. Suspending eligibility supports the goals of ensuring that states limit coverage and payment to only the authorized Medicaid benefits and services during incarceration. And it also helps to make coverage and payment for full Medicaid benefits available as soon as possible once an individual is released from incarceration. We understand that some states may not be able to do or implement fully a suspension policy now, and they may propose alternative policies and procedures while they implement a full suspension policy. States will be offered through this demonstration a glide path of up to 2 years to fully implement a suspension policy if needed. Next slide, please. So this is another area where states have choices. States may include individuals in state and or local jails, prisons, and or youth correctional facilities for the provision of pre-release services. And states have discretion to propose the types of carceral settings that may be included. So states, for example, could choose just to provide services in state prisons. They could also choose to select individual carceral facilities. So for example, they could say, we only want to include state prisons that are in the eastern part of the state. States may also propose a phased approach to adding carceral facilities. So for example, in a state where one carceral facility would be ready to participate in the demonstration sooner than another, a state could describe in their application how they want to phase in the other carceral facilities. Every state, regardless, will be required to conduct a readiness assessment of each carceral setting before implementing the demonstration in that location to make sure that the carceral facility is ready. Now, states may include individuals in federal prisons in order to help link them to make application for Medicaid in the state in which they are intending to reside upon release. But federal prisons are otherwise not included in this demonstration as a setting for pre-release services. And in our state Medicaid director letter, we encourage states to work closely with their appropriate correctional facility partners in this process. Next slide, please. So the scope of healthcare services. In this demonstration, CMS has set a minimum bar for pre-release services. Those 3 services include case management, medication-assisted treatment, which includes both counseling and medication for all types of substance use disorder, not just opioid use disorder, and a 30-day supply of all prescription medications upon release. Next slide, please. So turning back to where states do have some choices and flexibility, the minimum floor was set by CMS in this demonstration opportunity, but states are encouraged to consider covering additional services on a pre-release basis. In our letter, we outlined a few services, including family planning, peer supports, community health workers or navigators with lived experience, other types of behavioral health services besides MAT, and treatment for hepatitis C. So the additional services, if a state chooses to include them, should be based on the needs of the populations they want to serve in their demonstration. And for states that do choose to include additional services, they will be expected to provide a justification in their demonstration application. Next slide, please. I want to dive in a little bit more deeply on the service of case management. So case management is a service that's described in Medicaid regulations, and it addresses the whole person needs. It includes comprehensive assessment, care plan development, referral and related activities, and then monitoring to make sure that individuals get those services. It includes access to medical, social, educational, and other services. It is the linchpin between the care that's delivered pre-release and then making sure that that occurs once a person is released to the community. We recognize that the case manager or case management entity may be different between pre and post-release services. And if that is the case, a WARN handoff is necessary in order to ensure continuity of services as a person transitions from incarceration to the community, and that the services they need do not fall through the cracks during that transition. I want to point out that once a person is released from incarceration, they are no longer receiving Medicaid pre-release services through the demonstration. They can receive the Medicaid services to which they would otherwise be entitled through their state Medicaid program. Next slide, please. Another area where states have some choices. States may cover services in person or delivered via telehealth. CMS prefers in-reach services by community providers, but we recognize that there are provider shortages, which are particularly acute in rural areas, and states do have the option to use carceral healthcare providers in their demonstration for pre-release services. For states that do rely on any carceral healthcare providers to furnish pre-release services, they are expected to ensure that these providers comply with Medicaid provider participation requirements. Next slide, please. Another area where states have some choice. The Support Act said that states will generally be expected to cover demonstration services 30 days immediately prior to an individual's expected date of release from incarceration. In our state Medicaid director letter, we are offering flexibility to states to begin pre-release coverage up to 90 days prior to the expected release date. We recognize that some people may need a longer runway of pre-release services in order to transition successfully to the community. And if a state does request pre-release services for longer than 30 days for any duration up to 90 days, they're expected to incorporate into their proposal one or more elements to be tested in that additional period of time. Next slide, please. So state Medicaid agencies' information technology systems costs may be eligible for enhanced federal funding. And this may include IT systems that help to support data sharing between state Medicaid agencies, correctional agencies, carceral facilities, Medicaid providers, and other types of systems that may be involved in helping to support Medicaid individuals moving from transitioning from incarceration to the community. And funding is available for both new systems, IT systems, as well as improvements to existing IT systems. Next slide, please. Another area for state flexibility is states may request traditional non-service expenditures through their demonstration. They may request time-limited support in the form of federal funding from CMS for certain types of new expenditures that may be required by states, correctional facilities, and healthcare providers to implement and expand service provision and coordination. And a few examples that we list in the letter are developing new business and operational practices, stakeholder convening, education, outreach, as well as workforce development activities. Next slide, please. So the reinvestment plan is something that all states are required to do. This is not at state choice. CMS does not expect to approve state proposals for any existing carceral healthcare services that are currently funded with state and/or local dollars unless the state agrees to reinvest the total amount of federal matching funds received for these services under the demonstration into activities and/or initiatives that increase access to or improve the quality of healthcare services or health-related social services. And states are expected to include a reinvestment plan with their implementation plan, which I'm going to be talking about shortly. In the reinvestment plan, states are expected to outline the aggregate amount of federal matching funds for carceral healthcare services currently funded with state and/or local dollars and where reinvestments will be made. Next slide, please. Any investments in carceral healthcare are expected to add to or improve the quality of healthcare services and resources for incarcerated individuals and to supplement and not supplant existing state or local spending on such services and resources. And a few examples we included of reinvestments in the letter are improved access to behavioral and physical healthcare services in the community, improved health IT and data sharing, and increased community provider capacity that has the expertise and is attuned to the needs of the criminal justice involved population. I want to also point out that the state's share of expenditures for new, increased, or expanded or enhanced pre-release services approved under the demonstration would be considered an allowable reinvestment. And I want to put an exclamation point on this final bullet on the slide. CMS will not approve a reinvestment plan under which any funds are used to build prisons, jails, or any other types of carceral facilities, used for non-health related improvements for any such carceral facilities, or to increase the profits for private carceral facilities. Next slide, please. So the implementation plan, monitoring, and evaluation. All three of these components are required in all reentry demonstrations. So states have to submit their implementation plan to CMS. It is subject to CMS review and approval. And states may not claim any federal matching money for pre-release services until their implementation plan is approved. States will be required to conduct systematic monitoring of their demonstrations throughout the life of the demonstration. And through this demonstration opportunity, states are expected to conduct robust evaluation. Next slide, please. So let's talk a little bit about the lay of the land with state interest in these reentry demonstration opportunities. So CMS approved the first reentry Section 1115 demonstration opportunity in California back in the end of January of 2023. At the end of June, we approved Washington State's reentry demonstration. There are 14 other states that have applied for Section 1115 reentry demonstrations. Any application to CMS to pursue this reentry Section 1115 opportunity is subject to 1115 transparency requirements. And so I am going to turn back to something that I began the presentation by talking about, and that is the variability among state Medicaid programs. And just like the variability among state Medicaid programs, each state's demonstration application is somewhat different. Typically, there is significant discussion and negotiation between CMS and a state throughout the demonstration review period and leading up to and including the approval process. There are other federal partners that may be involved in review of Section 1115 demonstrations. And for our corrections leaders and correctional entities and various agencies in the audience today, if you are in a state that submitted a reentry application, we encourage you to work with your state Medicaid agency throughout the review and implementation period. And for corrections leaders, entities, and representatives in states that have not submitted an application, we encourage you to engage in a dialogue with your state Medicaid agency to explore the feasibility of a reentry demonstration application. Thank you so much for your time and attention today, and I'm going to turn back to Ruby. Thank you.
Thanks, Nancy. And thanks so much to everyone who keeps putting their keep your questions coming, but also it's great to see your names and your titles and the agencies that you're representing, the parts of the country that you're representing. If we could advance to the next slide. And Hallie, let me know if you want to get a word in here. If not, I will keep going.
Oh, thanks, Ruby. I was just going to thank Nancy for breaking that down so clearly. I know that there is often a language barrier almost when it comes to Medicaid, and I think she and her team did such a great job laying this out. As we're focusing on the corrections audience that are BJA's key stakeholders, Ruby, I'd love to hear from you, sort of, you know, when you think about the folks you work with in state corrections, local corrections, can you talk a bit about what you see as the opportunities here and why BJA is so excited about this particular opportunity?
Yeah, definitely. Yeah, this is huge. And I think, you know, just the strong and intense interest from all of you joining today realize that, you know, whether you're in one of the states that are still waiting to hear back from CMS, you're in one of the states that's in negotiation, or you're nowhere near that, we're hoping really to meet your information gaps and your information needs. But just thinking about the barriers first and then the opportunities, just working at this intersection of public safety and public health, and in this case specifically corrections and behavioral health, I think first it's really important to reemphasize some of the points that Nancy made earlier, that a lot of the people, kids coming home from juvenile justice facilities, adults coming home from criminal justice systems, jails and prisons, have really significant health needs, including behavioral health needs and definitely including mental health and substance use disorders. We know that people face stigma, face legal barriers when they're coming home from the community, whether that's, you know, a short jail stay, let alone years of incarceration, that people are experiencing barriers to finding housing, employment, benefits, and definitely health care. A lot of people don't have the community or family-based supports to help them with that transition. And we know that people that are coming home to the community after a period of incarceration, they've told us about, you know, really specific barriers that make it hard to accessing health care. They don't have the documents that they need, Social Security card, licenses, other ID cards, think birth certificates, other records. They might not know how to choose a health insurance plan or how to fill out that application for health insurance, or let alone, you know, how their health records transferred from the institution that they have into a community provider. And when people don't have health coverage and they need substance use disorder treatment or mental health treatment, they can have a really difficult time getting the care that they need, and they're then much higher for using those costly emergency department and inpatient services. So if we can address public health needs, especially treatment of substance use disorders, we can improve public safety. And, you know, especially for people with substance-related criminal charges, we know that they've got a higher risk of criminal reinvolvement and recidivism. So if we're thinking about successful reentry, we've got to be thinking about how to connect people with needed physical and behavioral health services before release to treatment and care, and improve that continuity of care post-release. And I also think that there's a lot that we can do in these efforts that can be done with an eye towards reducing disparities. If we could advance to the next slide. I wanted to also share with folks just a number of ways that are available already through the federal government, through my agency, the Bureau of Justice Assistance, through grant programs, through training, through technical assistance. I want to make sure that you know that their supports and services are ready to get you thinking about this and get on your way. The Second Chance Act was signed into law in 2008. For folks that don't know, it created the National Reentry Resource Center. That is a national hub and resource where we post lots of training and funding opportunities. This webinar will be available there. It also authorized the Bureau of Justice Assistance to make grant funding available to states, to localities, to tribes, to community-based organizations to support reentry efforts. And a lot of times that includes funding to support increased access to substance use disorder treatment, both during incarceration and during that continuity of care process during reentry and recovery supports after release. I also want to make sure that you know about some other funding opportunities that we have available specifically for behavioral health through the Comprehensive Opioid Stimulant and Substance Use Program, COSUP, another program behind the walls to increase the quality and availability of substance use disorder treatment is the Residential Substance Abuse Treatment Program, or RSAT. And through these programs, our grantees have been able to pay for things like personnel, case managers, reentry coordinators, pay for medication, whether that's psychiatric meds or FDA-approved medication to support medication-assisted treatment, naloxone. Lots of different things can already be paid for through grant funding to kickstart some of these activities if that's something that you haven't done already. In addition to the grant funding that I just talked about through all of those programs, we offer training and technical assistance to every single grantee that we have active, but also to the field at large. And I feel like that is not something that is super well known. To support, we can do training and technical assistance for anybody that asks for it, particularly if it's to support adoption of what we know works in reentry, things like medication-assisted treatment. We can also provide support like through tailored resources, through virtual training events like this one, virtual coaching, learning collaboratives, mentor sites, and we've had a lot of success with peer-to-peer connections. And I am guessing that a lot of people are going to want to learn from California, from Washington State, and from the others that come successfully through the implementation of these 1115 waivers. Whatever we can do to support and share information about what's working in those experiences, that's going to be really important for us to do and show up for the field. On the next slide, I think there's a lot of opportunities for improved outcomes here for corrections, the people that you serve in your care, custody, and control, and especially on the way out. Studies really demonstrate that connections between increased Medicaid access and reductions in recidivism. You heard Nancy talk a lot about improving care transitions and communication between our systems. I think if we can improve care transitions, we can improve the overall health of formerly incarcerated people, and that can be done just in two really basic, really critical ways. We can help people in reentry succeed and thrive when they're leaving incarceration, going back to the community, and we can reduce recidivism and make communities healthier and safer. This new reentry demonstration opportunity is focused on that coordination, on that continuity of care between and across the correction systems and the community health systems. That is a really unique opportunity that is opening up. I think both state and local governments can realize some cost savings, some efficiencies that you heard Nancy talk about too, about that reinvestment and improving quality of care for folks that are not within that range, the 30 to 60 to 90 days prior to release. When the folks that are coming through were able to serve or reimburse for their services through the waiver, it can help folks that are further out from reentry. I'd love to move on to the next slide. Great. So here you can see the light blue are the states that have already applied for demonstration. Nancy had those listed out on a slide. And then you can see the two states that were mentioned, California and Washington, that so far this year in 2023 have had those waivers agreed to. So states can design their proposals to make some really critical investments. You've heard about improving access to behavioral health and to physical health care services in both the correction system, the carceral setting, and in the community. You heard about some maybe lesser well-known opportunities on data infrastructure, data collection, communication systems for corrections, hiring and training staff to support the provision of in-reach services, addressing disparities and improving health equity, expanded and enhanced community-based reentry services and supports. Another thing I want to highlight is that it can include really critically important funding for IT planning and that infrastructure help that might be needed to improve that coordination between corrections, Medicaid, and community providers. And that can also include supports for additional personnel that would be doing that kind of work. I also just want to talk about some of the types of services, just to reiterate what you heard from Nancy that can be included in these waivers. Types of services like in-reach, meaning pre-release case management, including enhanced case management, warm handoffs to behavioral health care in the community, service coordination. You've heard us say this, but I think it's very important to mention again, medication-assisted treatment with counseling. 30-day supply of prescription meds as appropriate for reentry, linkages to trained peers or community navigators. Just an amazing opportunity that cannot be underscored enough. One thing I just wanted to point out, although the U.S. territories are not listed on the map, they are eligible to apply. And then last slide for me. You could advance. Thank you. Just some consideration. So as states are developing waiver proposals, they have requirements for public notice and public comment that they've got to follow, so be on the lookout for those. You've heard us say one of the goals of the Reentry 1115 demonstration is to improve coordination and communication between these systems, between the correction systems, between Medicaid systems, between managed care plans, and those community-based providers. So corrections, you are central to the success of these demonstrations. And a lot of you might be at different stages of readiness. I think one of you asked a question, what does it mean to be ready? And so I'll just talk about that for a little bit here before we open this up for questions. Some of the things that I would love for folks to be thinking about, or you can ask yourselves if you are one of the folks participating from a corrections department, from a jail, a sheriff's department, are you now conducting universal screening for substance use and serious mental illness during intake? Do you have policies and have you implemented them for managing medication-assisted treatment, medication for opioid use disorder? Have you developed cross-sector agreements and coordination to provide for in-reach care coordination and discharge planning? Have you already taken advantage and implemented things like telehealth and telemedicine to do that in-reach care coordination? Have you started the process of becoming designated as a qualified entity for presumptive eligibility, or done things like establish relationships and communication with state and agencies and managed care organizations to automate suspension in lieu of termination and to work on reinstatement of Medicaid? These are all examples of things of what it would mean to be ready. So I think that's another thing that we can do to provide some checklists or some quick self-assessments that jails and prisons and corrections systems can do and can think about to assess their level of readiness. And then really lastly for me, I lied last time when I said that was my last slide. If you can advance, just the last thing that I want to leave you with is I hope it's really clearly come through today that the importance, especially for folks on the correction side, of being in touch with your state Medicaid agency. So this slide shows the website for the National Association of Medicaid Directors, which you can find to use the right contacts for your state if you need it. There are opportunities with the Reentry 1115 waivers for corrections leaders that I want to leave you with. You can, move your state towards making a waiver application, including letting your state Medicaid director know that you're interested in this opportunity and then participating in the planning process. If you're in one of the states that already has submitted a waiver application, you should still make sure that you're at the table to understand what's in that application and help shape the implementation planning. If you're in California or Washington, congratulations. You already have an approved waiver. There's a lot of implementation work that I've been hearing about that's underway. Make sure you're connected to it if you're not already. And we just really strongly encourage you to stay in touch. We've got another webinar that's going to be coming up soon that's going to focus on the experiences of specific states in their development of a waiver, including development of cross-sector partnerships. We know that a lot of this is unfamiliar potentially to a lot of folks in the audience, and I just want you to know that we really stand ready to support you to help translate the Medicaid language. You can see we've got amazing partners from CMS that are standing shoulder to shoulder with us so that states can make the most of this incredible opportunity. So thanks, Hallie. At this point, I will pass it back to you for Q&A. Thanks.
No, thank you so much, Ruby. Really appreciate it. Thank you, Nancy, as well. And thank you both for modeling the sort of partnership between Medicaid and corrections that will make this opportunity a success. So for folks who are joining us here, please take a moment to put your questions in the Q&A box. Please type slowly and use complete sentences. I've seen a couple come in that are missing words. And so I'm thrilled about the enthusiasm, but just want to make sure that we understand your questions clearly and so we can respond well. Nancy, I think the first question that's come through in a couple of different ways is around the timing of this opportunity. Does CMS have a limited number of demonstration plans that you can approve, or a certain amount of money that you're looking to spend and you're capped at? Can you tell us a little bit about the timing?
Sure. Thank you very much for that important question. So this is not a grant funding opportunity where there is a delimited number of particular states, but I do want to point out that, and I think this echoes something that I talked about and certainly that Ruby did too, is the complicated pieces of systems that do not have as much history together. And so we have certainly found in our discussions with states that this is a very complicated operational process, and it does take a while to do that. So there is not, there's no limit that we've set, but we recognize that the amount of discussion and negotiation with each state on their individual proposals is going to take some time. And unlike some of the other Medicaid authorities that people may be aware of in 1115 demonstrations, there is not a particular period of time that CMS has in terms of the review process.
Great, thank you. Another question that's come in is around different types of correctional facilities. So a waiver might apply to state prisons or county jails or city jails. How have you seen states address that, or do you have any advice as people are thinking about the different types of correctional facilities that might be covered?
That's another great question. And I am going to go ahead and echo the big theme of my presentation. If you've seen one state Medicaid program, you've seen one Medicaid program. That really is a discussion that needs to occur on a state basis. And I'm so glad that Ruby provided that link to the National Association of Medicaid Directors. We have seen proposals that have included all state prisons and county jails, or other types of, municipal jails, as well as youth correctional facilities. But we've also seen proposals that just identified state prisons. And so I think that there is tremendous flexibility, and a state is really going to have to assess what makes more sense for them. And that, I think, is probably really important in that dialogue between the Medicaid agency and corrections, what they think that they can do and what makes the most sense in that particular state.
Great, thank you. And I have one final question. Yeah, as we just said in the chat, I know we're getting to the top of the hour, so please do send us your questions in. As I said, they will inform future learning opportunities and resources. But this question has come in a couple of different ways. Often release dates are unpredictable, whether it's in a county jail or due to a parole board decision. Do either of you have any advice about how to think about 30 days pre-release or 60 days or 90 days pre-release when you don't know exactly when somebody is going to be released?
I can jump in, and if Nancy, you want to start, the options, is with the option of up to 90, and for defined benefits and reimbursable services. I think knowing that release date is going to be really important here, and if there's an option or an opportunity through parole eligibility for that date to move up, I think looping in the state parole board is going to be really important to the planning process as well, so that we can make sure, as there's more certainty of a release date and that sooner and then well within the window for reimbursable services, that care and reimbursement is coordinated. Nancy, I don't know if you would add something there.
Thank you so much, Ruby. I think that is one complex operational piece that we have heard from in a number of states. And I think we know on average what jails nationally, it's about 30 days. And there may be more predictability in terms of state prisons, but I do think you're right. I think looking at that kind of communication ahead of time to try to get those communications more settled, to see if that is something that states can begin to figure out for this demonstration, may be one of those good things that can happen in improved communications.
Yeah, I think that really underscores too that we're talking about really variable populations, right? This can apply, and we saw this in the California waiver, to juvenile detention facilities, to people reentering from jails, and also state prisons. And those are really different populations. The state prison population is going to be way more stable and reliable in terms of release date. That the option or the consideration was those that have a difference or a moved up release date due to a parole decision. But for the jail population, those are typically, right, much shorter stays.
Absolutely. I mean, different worlds. And again, a place with state choice, and states may make choices. I've seen a couple of comments in the chat where some folks said that, maybe it's best to start out with state prisons because of that, but not every state has certainly chosen that, that way to do it. But many, many things to think about and to work on. But it's just the beginning of such an exciting opportunity.
Well, thank you both so much. I'd like folks to stay with us for a moment because we have a couple of helpful pieces of information moving forward. First is the information to stay connected with BJA. As we said, we will have some follow-up distance learning opportunities, resources, and we love to continue to work with you to understand this opportunity and pursue it in your states and communities. Next slide, please. We'd like you to take a moment. A poll is going to come up and let us know, what are you going to do today as a result of the information you just received? I've seen some people in the chat say, wow, this is the first time I heard that my state applied for a waiver and got it. And other people might be saying, this is an opportunity for me to reach out, find out who my state Medicaid director is. We'd love to know what you are taking away from this distance learning opportunity. So please take a moment to fill that out. We will also be following up with you. Please keep your eyes posted for a survey that is going to come to you from our team at the Justice Center, asking you about questions that you have and training and technical assistance needs, so that we can make sure that as we're working with BJA and CMS on resources that are coming up, we're really addressing the needs that you have. My colleague, Amy Button, has generously volunteered also to be available as a point of contact for folks who have questions coming out of today's webinar. So we'll put her contact information in the chat. She's a project manager on our team, and we'll be happy to make sure that you get the information that you need. I'll take another moment to just fill in the poll, and then we will close it. We will also, as we've said a couple of times, we've been recording the webinar today, and we'll be posting the link to the recording as well as the slides shortly. As I said, please stay tuned for the survey and to submit additional questions and provide feedback on the webinar. And now I'd like you to join me in thanking Nancy and her team from CMS and Ruby from the team at BJA and OJP for joining us today. Thank you so much for showing us what this opportunity looks like for a corrections audience.
Thank you.
Thanks, Hallie, and your whole team for helping us to get this really important information out. And thanks to everybody who joined today.